What's up, everybody? Dr. Rossi here at Shrinks and Sneakers. I'm a board certified psychiatrist making mental health content here on YouTube and various other platforms. If you're new to the channel, I'm going to ask you to go ahead and subscribe to the channel. It helps me to know this material is helpful to you and it's providing value in your life. And if you're returning, I appreciate the love and support as always. So today's topic is going to be major depressive disorder with psychotic features. Now, this is a diagnosis that I often receive questions about, and it can be really confusing, right? Because how do we know if the person has schizophrenia? How do we know if they have schizoaffective disorder? Or what about bipolar disorder with psychotic features? All of these things can be very confusing. So, they all have psychotic symptoms such as delusions and hallucinations as common core features. So in this video, what I'm going to do is explain to you how we navigate this diagnostic dilemma. Let's start with some of the basics, right? I want to take you guys back through the diagnostic criteria for major depressive disorder because for one to be diagnosed with MDD with psychotic features, they must meet criteria for major depressive disorder as defined by the DSM-5 TR. Now, as a reminder, to meet the criteria, the person must have 5 of 9 symptoms within a 2-week period, and at least one of those symptoms must be either depressed mood or loss of interest. In medical school, they teach you a really clever mnemonic called SIG-E-CAPS. And an interesting fact about this mnemonic is that it's written the way you would fill out a paper prescription for depression treatment. So SIG, energy capsules is what it stands for. And this is what you would give a patient or a person with major depression because of the low energy and loss of interest commonly seen in these depressive episodes. So it's SIG energy capsules, and the SIG-E-CAPS, each one of those is one of the 9 criteria to diagnose major depressive disorder. Now, I promised you guys I would talk about the other criteria. So I said you must have either depressed mood or loss of interest, but the other criteria that you can have to complete the 5 out of 9 symptoms required to make the diagnosis will include things such as weight loss or weight gain, so basically some type of change in your weight as a result of the depressed mood, insomnia or hypersomnia, so either not sleeping at all, not being able to fall asleep at night, or sleeping too much, what we call psychomotor agitation or retardation. In my experience, psychomotor retardation is more telling of a depressive episode. You could have fatigue or loss of energy. You could have feelings of worthlessness or guilt. You could have poor concentration or focus, as well as recurrent thoughts of death or suicidal ideation. So what we have here at this point is we have a person who meets the DSM-5 criteria for major depressive disorder. They have 5 out of the 9 symptoms over that 2-week period. Now, what if, along with this major depressive episode, the person also has some loss of reality-based thinking in conjunction with their major depressive episode? So not only do they have depression, but they also have loss of reality-based thinking. Now, what does that include? That will include things like delusions and hallucinations, with the delusions being slightly more common, but hallucinations are also common in depression with psychotic features. Now, the delusions can range from persecutory to paranoid, and other types can occur as well, but those are more of the common ones that we see. Now, with the persecutory delusion, these are ones where the person feels attacked or victimized by others. They may even believe that people are coming into their home to harm them. They'll usually point to things like things being misplaced in the home, or something's out of order, something that they put somewhere wasn't in the place they left it last. And they'll point to this as evidence to support this delusional thinking that somebody is coming into their home and trying to harm them. A common paranoid delusion is one where the person believes they are being followed. They believe they're being watched in some way. And they'll usually present evidence of a car that's commonly parked outside of their home, or a car that they see on the way to work every day, or a person they keep seeing on the street or something like that. And they simply cannot believe that this may be a coincidence, or it just may be someone who travels to work the same route every day in the same way that they do, but they're unable to really appreciate that fact. Now, the reason behind that is because a delusion is defined as a fixed false belief. So although there may be rational explanations for the things that are going on around this person, the patient's reality is not the same, right? Their reality is this delusional thinking. This is real to them. It feels real to them. It's distressing to them. And you also, as the clinician, have to understand that this is very real to them, even though you might see other ways of explaining it. And you have to be very, very careful when you challenge somebody's delusions. You don't want to just come out and say to the patient, hey, you know what? It doesn't make sense what you're saying. It's likely that that person you keep seeing every day just works in the same office building as you, right? Like if you do that and you present that information, they're not going to buy it anyway. It may be perfectly reasonable explanation. It may even be true, but it doesn't matter. These are fixed false beliefs. So one of the most important points I want to present to you guys here is that these psychotic symptoms, these delusions, hallucinations, this disorganized thinking that's going on, it's only happening in the presence of a major depressive episode. That's very important. That is your key point. So in order to be diagnosed with depression with psychotic features, these psychotic features only occur when the person is in the midst of a depressive episode. They don't occur outside of the depressive episode. So for example, if you treat the depression effectively, the psychotic symptoms resolve. If the psychotic symptoms remain after the depressive episode is successfully treated, then you need to reevaluate your diagnosis. So that's one of the main ways that we separate major depressive disorder with psychotic features from schizophrenia, is that these psychotic symptoms are occurring only within the context of the depressive episode. Now you might be saying, well, what about bipolar disorder with psychotic features? Now, this can present the same way. The psychotic features will happen during an episode of mania. So the person will be in the manic phase of bipolar illness, and often the delusions will have a grandiose nature to them. There'll be grandiose theme associated with them. For example, the patient may believe that they are a prominent religious figure. They may believe that the government is plotting against them and they're the only ones who can uncover the story and unravel this complicated plot against everyone in the United States. They're going to be the one to save the world, or whatever the case is. So there's a grandiose nature to it. Again, similar concept, but likely to occur during mania or during the manic phase of illness, and likely to have a grandiose theme associated with them. That's not always the case. Other things obviously can happen too, but that is the more common scenario. The delusions associated with the depressive episodes also tend to be somewhat reasonable. If you believe that somebody is watching you or following you, it's possible that they are, right? We don't know. Maybe they are. In things like schizophrenia, the delusions are usually bizarre in nature, although they can also be plausible. So it becomes very nuanced, but in general, that's what we would be thinking about here. The final point I want to make about the delusions associated with depressive episodes is that they tend to be what we call mood congruent. So when I say mood congruent, what I mean here is that they're consistent with how the patient is feeling. The person's feeling depressed, so they're having persecutory delusions. So it's not a far stretch for a person who is severely depressed to feel like people want to harm them for no good reason, right? This would not be that far of a stretch to make. And you can see how it can be mood congruent for the patient going through a depressive episode. Now, the treatment for major depressive disorder with psychotic features is actually well established, and it generally consists of two forms of treatment. The first one is medication treatment. In a medication-based treatment, you're going to combine a medication such as an SRI, so a serotonin reuptake inhibitor, or other antidepressant medication, with a dopamine blocking medication to treat the psychotic features. Now, the dopamine blocking medications could be any examples here. It could be aripiprazole, it could be risperidol. There's many different options there, and you're going to make that selection largely based off of the side effect profile and what the patient can tolerate, because these medications do have a much more difficult side effect profile to tolerate. So we have to be careful which ones we select. The other option outside of medication management is to undergo an index phase of electroconvulsive therapy, or ECT, and this is usually for the person who is severely depressed, who's not eating, not attending to ADLs, and is in danger of harming themselves in some way. Now, patients should remain on medication for at least 6 months. There's some debate about this, but in the research that I've done, 6 months seems to be the right amount of time to remain on both the antidepressant and the dopamine blocking medication. And this is very important because there was a recent paper that came out that showed that relapse is likely to occur if you are to stop the dopamine blocking medication specifically earlier than 6 months. So my recommendation to my patients is always to remain on the medication for 6 months and then consider tapering off of the dopamine blocking medication at that point to see how the person does. As far as the antidepressant medications go, those should be continued for at least a year, and then at the point where the person has been in remission for 12 months and has been asymptomatic, you can start tapering that medication off and see if symptoms recur. If they don't, great, you can come off the medication fully. If symptoms develop again, then you can taper down to what we call the lowest effective dose and remain on it for a longer period of time and reassess clinically several months later. So the difference here being 6-month period of time that you should be on the dopamine blocking medication and about a 1-year period of time to stay on the antidepressant, at which point when 6 months is over, you can start to taper the dopamine blocking medication, and at the 1-year mark, you could begin to taper the antidepressant and see if symptoms recur. If not, great, then the person could come off the medication fully. If somebody chooses to do the index phase of ECT, it consists of a total of 12 sessions, which are usually completed over a 1-month period, and you would normally be doing the sessions 3 times per week, usually every Monday, Wednesday, and Friday. If somebody is having difficulty with the treatments and tolerating them, they can be done twice a week, say Tuesdays and Thursdays, with more time in between treatments. With that said, I'm going to go ahead and hold the video here. I'd love to take your questions and comments below, and if you haven't done so already, please subscribe to the channel. It really helps me to keep making this content for you.